So this is why we're going to talk about this stuff tonight. This is why we talk about hip fractures. This is a real case you're going to see within your first 2 weeks ever walking in an ER in orthopedics. This is a real case. I actually know this surgeon very, very well. There's a 56-year-old, very healthy, very active orthopedic surgeon, was riding his bicycle in Princeton, New Jersey, and got struck by a car. And that's all you got. So now you're looking at this x-ray. And this is a young, healthy, active one of us, right? Part of our orthopedic family. And we've got to decide what's going on with him. What do we need to do next to make sure he's well taken care of? And then how are we going to make this better in a way that gets him back to the life he needs to live? And that's what we're going to go through tonight. How do we interpret what's going on? How do we decide how and when to act? And what do we do to try to make it better? So like every good talk, we have our little outline, and I'm going to spend the vast majority of our time on these first 3 topics: anatomy, imaging, and our basic clinical assessment, and understanding how to look at a hip fracture and understand what you're looking at, what's important, and what you need to consider. And at the end, we'll go through some cases to talk about sort of treatment options and things like that. But I think if you focus really on anatomy, imaging, and assessment, you're going to get most of the information you need from this evening. And the real focus is anatomy. Right? For those of you who don't know who this is Jack Houston. Jack Houston started the Houston Clinic in the 1940s, one of the first orthopedic specialty clinics in America, and still the oldest orthopedic specialty clinic there is, one of the fathers of orthopedic sports medicine. And he used to say all the time, whenever you're having an anatomy session, pay particular attention, because orthopedics in its essence is just anatomy and a little bit of common sense. So let's start with our anatomy. We're talking about the proximal femur. We're talking about hip fractures. What do we mean? We mean the proximal portion of the femur from 5 centimeters below the lesser troch up to the femoral head. That's the area that we talk about in hip fractures. Kelly, Joe, give me a nod if you can see my pointer on the screen. Great. So we're talking about everything from here up. This is our greater trochanter, our lesser trochanter, probably things you remember from anatomy, but I also remember being a 4th-year medical student, and anatomy was 3.5 years ago. So a little bit of review is not the worst thing in the world. You've got this intertrochanteric line, very simply the line that connects the greater trochanter and lesser trochanter, and the area called the femoral neck. And this is going to be very important to understand the difference between these two. And we're going to talk a lot about why that even matters. It's, 3 centimeters away from each other and makes a complete difference in treatment, complete difference in prognosis, and complete difference in how we evaluate these patients. Your femoral head usually has some remaining fovea. This is the femoral head, and the femoral head obviously sits inside the acetabulum. So the real anatomy that we need to remember and understand here is the capsular and vascular anatomy, because the vascular anatomy of the proximal femur is the entire guidance for how we treat these injuries, what we're going to do, and how they're going to do long term. All of the blood supply to the proximal femur comes off the femoral artery in one way or another, whether it's deep femoral artery or the superficial femoral artery. Most of it is branches of the deep femoral artery, the most important of which is this medial femoral circumflex branch here that wraps up and around, and these ascending branches which give blood supply to the capsule of the femoral neck, mostly on the top. And I'm going to show you some incredible images that some of my colleagues have done to really understand the blood supply to the femoral head. As we go through most of tonight, almost everything's going to come back to where is the blood supply, is it disrupted or not, and how likely are we to have bone in the proximal femur that survives the insult of the fracture. So again, our relevant anatomy is really nicely seen in this image. This image is stolen from Rockwoods, but this image you can see when you put dye into the vessels, these vessels come up and start to give femoral head blood supply off the superior aspect of the femoral neck. And again, you can see that kind of coming right here, but the images get a lot cooler when you expand out just a little bit. So if we look here at this image all the way on the left side of your screen, you can see the greater trochanter, and you can see blood vessels all over the place coming through the obturator externus. There's always a blood vessel right along the piriformis, and each of these dive deep as branches of the circumflex arteries that come up the deep femoral artery. Here, on the right side of the screen, you really get the opportunity to see not only this ascending branch, but the capsular branches that come out onto the top of the femoral neck, reminding us that the majority of the femoral head blood supply comes on the superior aspect of the femoral neck. So disruptions of the superior aspect of the femoral neck are going to be problematic for long-term blood supply of the femoral head. And if you don't think this is true, check out this MRI. So this is a gadolinium enhanced MRI of the proximal femur with dye injected into the deep femoral artery. And you can see when you look across this MRI, all of the blood supply to femoral head is right here and right here. In fact, there's almost nothing else. One branch here, a little branch here. Almost every piece of blood supply going to the adult femoral head comes off the superior aspect of the femoral neck inside the capsule of the hip. Because if we go back, you remember the capsule encompasses everything off the inner surface of the greater trochanter right onto the acetabulum. So that blood supply is all stuck inside there and really just mostly running along the top, running along that superior aspect. And if you keep that in mind, you can pretty much understand everything we're going to talk about from now on, because a lot of it's going to be based on where is our fracture, how's our blood supply, and is there something we need to do in an expeditious fashion to try to restore that blood supply. The other anatomy, because this is orthopedics, is the bony anatomy. Besides the fact that we've got our greater trochanter, lesser trochanter, femoral neck, femoral head, intertrochanteric line, we also have to understand the way that force passes through the femoral head and neck. There are patterns in the trabecular bone that build tougher, stronger bone right here in what we call the calcar femorale, which is the junction of these trabeculae that are in line with weight bearing. So if you remember back to things like Wolff's Law, where you talk about that bone is present in response to stress, as weight comes through the femoral head and down the femoral neck, it follows these trabecular lines. So you will get very, very strong, hard bone right down here in that calcar of the femur, and weaker bone up top where the weight is not necessarily transmitting. This W stands for Ward's triangle. Ward's triangle is this empty space in the middle of the femoral neck that is sort of inside of these trabecular bone patterns. The question of where is the exact location of the calcar that I see in the Q&A, it's right here if you can see my pointer. It is the most medial aspect of the inferior femoral neck, and it's just that really, really hard bone that supports the inferior surface of the femoral head. The problem is if you follow these trabecular lines is that really good strong lines coming down into the calcar, pretty good strong lines across the intertrochanteric region, and right in the middle is a weak spot, a spot that weight does not tend to pass through very well. We call that Ward's triangle. It's an area at risk in the femoral neck. So every time we see a patient in the ER, and I'm sure Joe can sort of feel this pain more than anyone else, you want to make sure you at least have an X-ray. What I always used to joke with the ER doctors, and my brother-in-law's an ER doctor, was you wouldn't call the cardiologist without an EKG, right? You shouldn't really call the orthopedist without an X-ray. The corollary to that is you better know what that X-ray looks like, and you've got to understand what you're looking at. And the most important thing to know what's normal, so you can say, hey, what's not normal? So if we evaluate this AP radiograph of a proximal femur, right? It's a hip plus some of the pelvis and some of the proximal femur. We want to be able to look at this image and say, okay, I know the anatomy in the anatomy lab. What am I seeing right here? So we can take it and outline it, break it down into all the things that we already identified and what should they look like on this pretty standard looking AP radiograph of the hip. So we've got the pelvis, right, which has the ilium, the ischium, and the pubis. And really, when you're starting to work in the ER and thinking about fractures, you've got your superior pubic ramus and your inferior pubic ramus. Remember, these are very commonly injured in ground level falls in elderly patients. And so you may see fractures of those in a patient in whom you're evaluating for a hip fracture. And then, of course, there's the anatomy of the proximal femur, the femoral neck, the greater trochanter and lesser trochanter. You can see here outlined in yellow, and the femoral shaft moving down. And again, understanding how these look like on a good X-ray, right? This is a very nice, good technique X-ray, is helpful when you start to get X-rays that aren't so good. Really, really, really great. Most importantly, thank you for staying awake for a whole 16 minutes of this. I'm actually really impressed. The X-ray on the right side of your screen is an X-ray in external rotation. And as very nicely pointed out by some of our attendees, the way we know that is you can see that lesser trochanter really prominently. The lesser trochanter is a posterior structure. If you can see it really well, it means that the hip is externally rotated and it's staring in the face. So the greater trochanter is now in the back, The lesser trochanter has moved very medial because it's in external rotation. And this is what a lot of our x-rays in the ER will look like. The problem is what you don't see very well on this x-ray is the femoral neck. So if you're trying to evaluate the femoral neck, this x-ray on the left side of the screen is a much better x-ray for evaluating the femoral neck because it's in internal rotation. It's a beautiful elongated view of the femoral neck that'll allow you a much better image. Sometimes this even requires going down to the ER, and I'm sure Joe can tell us about this, and actually internally rotating that patient's leg to really see what kind of fracture it is. The problem with this is you got to build a little bit of a stomach to do it, because as we all know, hip fractures hurt like crazy, and going down and hurting the patient to do it is not something that any of us take lightly or think is not important. But sometimes you've got to get that right x-ray so you can make sure you're doing the appropriate treatment for that patient moving forward. So as you can see, that's an internal rotation x-ray on the left side of the screen and external rotation x-ray on the right side of the screen. I didn't expect anyone to get that right. This is sort of the kind of stuff you want to learn. The fact that so many people did is super impressive and just reminds me that I definitely would not have gotten into orthopedic residency nowadays. I'm well past 40 years old, and I just look back and think, thank goodness I went into orthopedics when I did, because I'm not sure I'd make it in right now. I don't think I learned this till I was a fourth-year resident, and even then I wasn't sure I really knew it. I just made it up. The other thing you want to remember is for most of our x-rays that we get, we want two views, right? We always ask for those orthogonal views. Number one, what does orthogonal mean? Orthogonal means two views and 90 degrees to each other, right? So oftentimes you'll hear that you want to get two views of something, right? The most important lateral view you're going to get of the hip is this cross table lateral, but it's very helpful to actually understand how to do it. Because like we said, you really don't want to move their hip to get that lateral x-ray. It's going to hurt like crazy. So this is how you position for a cross table lateral view. You take the non-affected side, flex it up, basically put the x-ray tube in their groin and shoot to the plate on the outside of their body. And you can get this beautiful lateral view you see here. And what's very nice about this lateral view is, number one, you get a very nice view of the head, a good view of the anterior surface of the femoral neck, and a nice view of the shaft. And later on, when we get into a couple of case discussions, you'll see that the femoral shaft and the deforming forces on the femoral shaft are very important to understand. So now you've gotten your x-rays, which you looked at probably in the call room before you went down to decide how fast you need to walk to get there. And you said, okay, now I'm going to see this patient in the ER. So we're right back to this. This is our 56-year-old healthy orthopedic surgeon, got struck by a car while riding his bike. And this is what he looks like laying there in the trauma bay. You can see that right leg looks normal, sitting there, a touch of external rotation, like most of our legs look if we sort of lay flat. But then you see that left leg, right? Fully externally rotated, shorter than the other side. And this is going to be the classic pattern for a hip fracture. When you see a patient who's short and externally rotated like this, especially either a high energy trauma patient or an elderly patient after a ground level fall, you want to think, okay, this is probably a hip fracture. Combine this with a very gentle physical exam, because don't tell your professors I told you this, but you don't want to go crazy examining a hip fracture. It hurts, right? You want to check their pulses. You want to make sure their muscles move. Don't move their hip around. You're not actually helping them. It's just making them hurt more. But if you see this position of their leg, the x-rays we talked about, this is obviously going to be your diagnosis of a hip fracture. There are some other things that can also make your leg shortened and externally rotated including some kinds of femoral shaft fractures. So don't think that this is absolutely conclusive, but you should have a high index of suspicion in a native hip that it's fractured if you've got a patient laying on your table like this. Also remember, if it's an older patient, you're like, okay, I think it's a hip fracture. Okay, I think it's a femoral neck fracture, whatever. Your next job is call medicine, right? You want to make sure you get the work started to get this patient optimized for surgical treatment. However, if this is that 50-year-old or 19-year-old after a motorcycle accident, the next person you call is the operating room, right? When you see this, you don't wait to kind of get it all worked up and figure it out. If there is a chance that this is a young patient with a femoral neck fracture, you want to get that patient in the operating room as quickly as possible. We're going to talk about that a little later, but keep in mind that initial physical exam assessment can give you very good confidence that you're on the right track, and you want to start moving forward to make sure you're doing the best thing for the patient. So now you've got your x-ray in front of you and you want to identify your hip fracture. So how are you going to identify a fracture? A lot of times the x-rays look like this. This is not a great x-ray. The patient's kind of rotated. The exposure is not great. You've got kind of dark black lines over this hip. I'm not sure which hip is even the broken one. You're sort of looking at it a little bit, but what do you see? You see a nice inline calcar, like we talked about earlier, right above the lesser trochanter on this right hip, which is on your left side of your screen. And on the other side, you can see that that line doesn't necessarily connect, right? That calcar seems to end underneath the lesser trochanter. You've got that big hole, right where we talked about that Ward's triangle, that sort of that bone was not very strong. That's your hip fracture, right? You don't know exactly what it looks like. You may not have your perfect classification yet, but you know that that left hip is not normal and is likely quite broken. You can take a further look and kind of see exactly what it looks like. This is a great example of something that you know is broken, but you don't really know how. This left side of the screen, you can see this left hip fracture, but the hip is clearly shortened. So you can't tell, is that an intertrochanteric fracture? Does that fracture go from the greater trochanter to the lesser trochanter? Or is this a very low femoral neck fracture and the trochanteric line is intact? Here's where doing things like manipulating the leg may be helpful. Again, not always the nicest thing to do to the patient, but in this case, you can see pulling some traction on that leg really brought that femoral neck down, exposed it to you to see, and you can see that the intertrochanteric line is intact. And this is probably a fracture at the base of the femoral neck. So evaluating your radiographs, understanding what you can and can't see, and then visualizing in your mind what the anatomy should look like will help guide you into what your next step in your diagnostic workup is going to be. Now, sometimes they just straight mess with you. Sometimes you get this call and this patient has a broken hip on the phone. You're 100% sure of it. You are walking down to that ER, ready for that broken hip, and you see this x-ray. And I'm not going to go out there and ask anybody if they see or don't see anything, but I will tell you the first 15 times you look at this x-ray, it looks pretty normal. So now you've got to be much more critical. If your physical exam and your history are consistent with a hip fracture, start being critical of your basic anatomy. Start being critical of your trabecular lines. Start being critical of your greater trochanter and lesser trochanter. Start being critical of your calcar. We're going to start on this left hip on the right side of the screen. Intact femoral neck. The trabecular lines going down to the calcar look great. The greater trochanter appears completely intact and in continuity with the shaft. The same with the lesser trochanter. And the calcar is perfect in a solid, thick, white line coming from the top of the lesser trochanter right to the base of the femoral head. I am fairly confident that that left hip is not broken. Go over to the right side. Femoral head intact. Trabecular lines look okay. Greater trochanter intact. Lesser trochanter intact. But wait a second, I said okay. Let's take a look at those trabecular lines one more time. Trabecular lines come down and then they sort of buckle, right? They make a little curve. And what's going on right here in our calcar? Our calcar actually looks a little thicker and has this little divot in it. This is a non-displaced femoral neck fracture. That is super, super easy to miss, but you can look like a real rock star if you see it by taking a close look at our anatomy and just following the basics of understanding what that x-ray should look like. The other thing is always check your second view, because you may have had a pretty normal looking AP view. Here on the lateral view, you can see if we follow that femoral neck, there's a very obvious gap here, and you can see the anterior displacement of this femoral neck fracture. So always check both of your x-rays and always carefully examine what you know is normal for that patient to try to identify these fractures that you might miss. Sometimes, doesn't matter how close you look, you're still convinced that there's a fracture there and you simply can't identify it on the x-ray. In that case, you might want to do a little bit of advanced imaging. So here's one patient, same day, with 3 different imaging modalities. So all the way on the left A, you see an x-ray. And I will tell you, I look at that x-ray and I see nothing at all. That x-ray looks very, very normal to me. Then we see that middle B, this is the CAT scan. Now this CAT scan is actually beautiful in regards to showing the trabecular lines we were referring to a minute ago. You see these brighter white lines that come down, and fabulously on the scan, they're in line with the trabecular bone of the acetabulum. sort of proving the existence of Wolff's Law, that where you transmit weight across the joint, which in this patient is right here, you have more bone. Bone is put in the place where it is needed the most. So you can watch these lines come straight from the top of the femoral head, straight down to the calcar, the whole way across, and then they end kind of right here. And this bone here, again, this is what I'm referring to as the calcar. The hardest bone in the proximal femur, it's the bone that holds up the femoral head. You also have an interesting look at Ward's triangle, where there's almost like a lack of bone here. Now, whether or not that's normal for this patient or pathologic is unclear, but it's interesting. You can see that the bone is almost missing right there. And then we go over to the MRI, and here's where I do think MRI can be very useful, because everything on this CAT scan even looks pretty normal. You could say there's a bit of a angulation here that might not be normal, but one could argue an osteophyte or bone spur could look similar to that. And then you come to your MRI, and obviously we've got the white arrow sign. For those of you unfamiliar with the white arrow sign, it's what the radiologists put when they want you to make sure you see something. It's very funny to me when they put it on the things that are the most obvious and not on the things that we would normally miss. But you can see here a fracture line coming down through the base of the trochanter and likely exiting somewhere over here. So this is a non-displaced intertrochanteric fracture of the hip, easily and 100% missed on the X-ray and even on the CAT scan. So this is why advanced imaging at times can be very useful. It's not necessary in your garden variety, I shouldn't have used the word garden, in your classic variety of hip fractures. But in general, for non-displaced fractures, for high suspicion where there's nothing else showing it, an MRI can be very successful and very useful for identifying these more non-displaced fractures. When we identify our fractures, we're really thinking of three things to understand our treatment. Where is the fracture? And like I said earlier, that is entirely related to blood supply. We want to know where the fracture is because it helps us understand if the femoral head is going to live or die through this injury. What are our fracture factors, right? And we know from the basics of fractures, there are really two ways to describe fractures. Fractures that are non-displaced, meaning the bones are still lined up where they belong, and fractures that are displaced. The bones are no longer lined up where they belong. And those are the types of fracture factors that exist in all fractures, whether it's the humerus, whether it's the femur, whether it's the hip fracture. Each of these we want to understand, is it displaced or non-displaced? And then a stratification of the morbidity of the injury, right? A displaced femoral neck fracture, the ball fell off the femur in a 19-year-old has a very different morbidity stratification than a 86-year-old with a femoral neck fracture. Their activity level is different. Their likelihood of long-term good outcomes is different, whether you fix it or replace it. And each of the decisions we go through are based on this stratification of exactly what this patient, who this patient is, what's their activity level, what's their longevity, what is their likelihood of healing if you fix the fracture. All of these things go into understanding what's our plan going to be for surgery. Each of these classification ideas guide treatment and, very importantly, predict outcome. And why do I say very importantly predict outcome? Because not honestly, when the outcome happens, it happens. Why is it so important that we predict it? And I will tell you that I would bet Kelly is so much better at this than I am, but the understanding of how to speak to a patient and help them understand what their future is going to look like, obviously something oncologists probably deal with on a daily basis in very, very complicated ways, is super important. So you're going to talk to this patient in the ER. They're not a broken hip on an X-ray. That is a person on the table. And you're going to talk to them and say, hey, you have a broken hip. We're going to do this, and here is what you can expect. And when you guide them through that, when you help predict that outcome, you calm their anxiety, you become their doctor, and more importantly, you give them an opportunity to understand their injury and understand their treatment a little better, which is what all of us as patients really want. So subtrochanteric fractures are considered types of proximal femur fractures. Interestingly, even though they happen below the intertrochanteric line, we consider them hip fractures, even though they're not really in the hip. To be fair, you can't actually fracture a hip. The hip is a joint. You can dislocate a hip. When we talk about hip fractures, we're really talking about fractures of the proximal femur. And so since we term fractures of the proximal femur as hip fractures, subtrochanteric fractures are considered hip fractures. That, I know we just got that question. That's kind of the best answer I have for that. beyond 5 centimeters below the lesser trochanter, beyond that subtrochanteric region, that's now a femoral shaft fracture. And the reason those two are different comes back to anatomy. The deforming forces on the subtrochanteric femur are different than on the femoral shaft because of the attachments of some of our muscles as we go down the thigh. So when we talk about this classification, we said we're going to talk about location. Location is entirely based on blood supply. We're going to break our hip fractures down into two types of hip fractures. What we call pertrochanteric hip fractures, which we used to call peritrochanteric hip fractures, which we used to call intertrochanteric hip fractures, and then decided we didn't like that. I'm not part of the AO. I don't know why they keep changing the names, but in general, there's fractures outside of the hip capsule, meaning the blood supply within the hip capsule and to the femoral head are maintained. That's really the only thing that matters. And femoral neck or intracapsular hip fractures, which you see down here at the bottom. And these are fractures that happen within that capsule. They disrupt those superior capsular arteries and therefore disrupt the blood supply to the femoral head, and therefore have a completely different treatment algorithm in how you're going to treat them and what their long-term prognosis is going to be. And if we ended this conversation right now, we're good. At the level of a first-year resident, that's what you need to know. You need to know your anatomy. You need to know how to evaluate an X-ray. You need to know how to evaluate and speak to a patient in the emergency room. You need to know how to classify an intertrochanteric or extracapsular hip fracture and an intracapsular hip fracture. But since you signed up for the advanced course today, you get 10 more minutes of me telling you some other stuff about it. So when we talk about it, we say, is it intracapsular or extracapsular? Meaning, is the blood supply still there or is it not? And then we start to think about the patient like we alluded to earlier. Are they young? Are they not young? Or are they old? And Kelly, you're much younger than me. And Joe, you're much, much younger than me. So once you pass 40, young and old start changing. Young keeps getting older and old keeps getting really old as you start to go through your practice. So be careful using these words around your attendings, especially if it's your first day you met them. You never know who just celebrated 40 or 50 or 60. So don't refer to them as old when they're 61 in case your attending is 62. Whether or not they have pre-existing arthritis, this is my wheelhouse, right? I'm a hip replacement surgeon. So I really care about this because it helps me guide some of my treatments if we go down the arthroplasty route. And then their ambulatory status, right? Because if a person can't walk, you're a little less concerned about the fact that their hip is broken than if they're an independent ambulator who runs marathons, right? And this is where you start to guide your treatment algorithm based on how the patient does. And here's our sort of basics of treatment. To the left side of your screen, again, over here, these are our intracapsular femoral neck fracture treatments, and those treatments are fairly straightforward. If it's not displaced, if the bone is still in continuity and you believe that the blood supply to the femoral head has not been drastically disrupted, you can fix the fracture. Most commonly with this screw configuration you see here, but you can kind of do anything you want as long as the idea is that you're fixing that fracture. If that blood supply has been dramatically displaced, the ball is off of the femur, it is displaced or in multiple fragments, you're going to go down the replacement route. So this is either a partial or a total hip replacement. In whom you do each is a kind of a complicated conversation, and also depends on who you are. I do total hips on basically everybody, but that's because it's almost easier for me to do a total hip than a partial hip because we don't keep partial hips in my hospital, but we keep lots and lots of total hips. In most cases, in the vast majority of cases, elderly patients with minimally traumatic femoral neck fractures are going to get partial hip replacements that are cemented, and that's fantastic, and they're going to do great, and that's the way to do it. If the blood supply to the femoral head remains intact, like you see here, even in the setting of, as you see way here on the right, a very complicated fracture pattern, these fractures are going to get fixed, right? Because you want to save that femoral head that's going to survive this injury. And whether you do with one of these plate and screw constructs, these super fancy, probably very, very expensive locking plates, or these what we call cephalomedullary nails that start at the top of the femur and go down inside the femur, almost becomes dealer's choice unless you've got significant displacement. And again, not really something you need to worry about so much tonight, as long as you recognize that intertrochanteric fractures are going to be fixed in some way, like you see on the right side of the screen. Femoral neck fractures will either be fixed or replaced depending on displacement. And just a quick word on osteoporotic hip fractures. These are fragility fractures. Remember that the diagnosis of osteoporosis is either a T-score, more than 2 standard deviations outside of normal, or, and much more commonly, a low energy fracture of the hip, spine, or wrist. most patients who come in with a hip fracture say, I don't have osteoporosis, I have osteopenia, I had my bone scan. Not true. If doesn't matter what your bone density scan shows, if you have a low energy hip fracture, you have osteoporosis. And the reason that's important is it is our responsibility as orthopedic surgeons to start treating that patient's osteoporosis. We want to prevent their other hip fracture. It's really, really important. We need to own the bone as we started doing about 5 years ago through many of the societies in orthopedics. And we need to remember that the most opportune time to start osteoporosis treatment is at the identification of the first fragility fracture. So remember that these happen. They've got a 7% in-hospital mortality rate, and 20% of elderly patients with osteoporotic hip fractures will die within 1 year. So you've got to remember that this is really, really important, not just to their hip, but to their whole life. And here's a great opportunity to intervene. So we had a question real fast on how can you tell if it's displaced or non-displaced? Well, check out this x-ray. This patient has bilateral femoral neck fractures. On the left side of the screen, the right hip, that is a non-displaced or impacted femoral neck fracture. You can see the calcar appears relatively intact. On the right side of the screen, or the left hip x-ray, you can see the ball is here and the neck is way up here. That is a displaced femoral neck fracture. We got a CAT scan because why not? Let's get some CAT scans, and people need extra radiation. And you can see here that while this femoral neck is fractured, the ball remains on top of the femoral neck. While on the left side, that ball is floating in the breeze. The only thing holding that ball inside that patient's body is the acetabulum. It is no longer attached to the femur. That is a displaced femoral neck fracture. And when we look at it in classification systems, we call it the Garden classification. Again, if you've got your Netter's book, it says it in there, but you just need to remember Garden 1 and 2. Those are non-displaced fractures. You can see the calcar remains intact, and type 3 and 4 fractures or displaced fractures are the ones where the calcar is disrupted or the head completely falls off. The ones at the bottom of on the top of your screen are the ones we're going to fix. Again, we're going to use those screws and fix it. The ones at the bottom of the screen are the ones we're going to likely replace or urgently fix in a young, healthy patient with polytrauma. There's a concept called Powell's angle, which talks about the angle at which the neck fractures has a lot to do with how successful we can be with fixing them. Just an understanding that this is what the angle is called is probably all you need at your level as you go through residency, especially as a 2 and a 3 when you're covering the ER and you've got a young patient with a femoral neck fracture and you're calling your trauma attending at night. You're going to want to know this Powell's angle. You want to know it's a 1, 2, or 3 because that's going to tell them how fast they're going to walk and what kind of surgery they're going to do when they get there. So again, back to this case of a non-displaced fracture on one side and displaced on the other. We've got that subcapital fracture on the right hip, the displaced fracture on the left hip. We're going to go for that fixation on the right hip and that replacement on the left hip. And I'm going to blow through this for a second to get us to where we want to be. And well, where'd that go? And we're going to treat it as such. We're going to treat it with that fixing it on the right and replacing on the left, which I thought I had an x-ray of, and I apologize. I don't have that next x-ray. What you don't want to do is fix it like this, where you put a lot of screws, but leave it in varus, because not every fixed fracture is the same. So here's a fracture fixed, theoretically, but not well, and you can see what happens. These fractures will fail over time if you don't fix them appropriately. And this is why it's important to understand the type of fracture you're dealing with, because you don't want to have to send this to go back to get an osteotomy and this very cool plate and screw contract that you get. You want to understand that you fix it correctly. So here's that x-ray that, sorry, got pushed a little bit out of order, but here's how we're going to treat that patient. The only thing I don't like about this x-ray, and I hope I'm not the only one on this panel who's a little uncomfortable with this x-ray, is the fact that hemiarthroplasty on the left side is not cemented. Hemiarthroplasties in elderly hip fracture patients should be cemented. It is a clinical practice guideline for the American Academy of Orthopedic Surgery, and it has a 20 times higher rate of complication if you do it with this technique. So I promise you, this is not my x-ray, because I would never have done this. I've cemented every single hemiarthroplasty I've ever done in practice, and you should too. But you can see both treatments of femoral neck fractures done in the same patient. So let's go on to those pertrochanteric hip fractures for our last couple of minutes while we got some time. Again, here is that fracture. You can see that very nice long femoral neck is intact. Our fracture comes right through the greater trochanter down, and you can see what happened in this multiple fragment intertrochanteric hip fracture where the lesser trochanter actually broke right off. It's very, very common for what we call a 3 or 4 part intertrochanteric hip fracture. And so we need to understand, is it a stable fracture where that posteromedial cortex is intact, or an unstable fracture where either there's significant comminution of the lateral cortex or the whole proximal femur fell off and you have a subtrochanteric femur fracture. And the reason it matters is our fixation devices often rely on a little bit of compression at that area as these fixation devices slide a little bit. But if you have no support in the back wall, they'll slide right off. And I'm going to show you an example of that in just a minute. So a stable fracture that has an intact lateral support, you can treat with anything you want. These called sliding hip screws are probably the standard of care. They're the least expensive, most cost-effective, and simplest surgeries to do with the lowest complication rate. The unstable fractures, where you lose that ability to stop the hip from sliding, are probably best treated with these cephalomedullary nails. They're great. They're easy. I'm sure Joe has put in like 3 today. When you're a resident, you throw these things in like candy, and you get very good at it. But remember that you're probably actually better off with these sliding hip screw devices in certain simple hip fractures. So if somebody wants to understand how is it stable or unstable, a simple fracture pattern that allows for the 2 pieces to compress together is going to be our stable fracture. You see out here way on the right side of the screen, that's an unstable fracture with fracture lines going across that lateral cortex. That one in the middle, you can kind of classify depending on how bad that trochanteric extension is. So stable has a backstop for sliding. You can treat it with the sliding hip screw. You can see beautifully done right here. Everything about this x-ray looks perfect. I also didn't do this one, although I'd love to take credit for it because this looks absolutely perfect. If this was on my boards, I'd be super excited about it. It does everything right. It's got a beautiful sliding hip screw. It's got that screw right in the center of the femoral head. It's got only 2 screws distally because that's all you need. This is an unstable hip fracture, right? This is what we call a reverse obliquely intertrochanteric fracture. That's not important, but what is important is you see the loss of integrity of the lateral cortex. If you put one of those sliding hip screws, this is what's going to happen. It's going to slide and slide and slide, and the proximal femur is going to slide right off the femoral shaft. That's not what you want. This is better treated with one of these intramedullary or cephalomedullary nails. So in this case, what we did with this unstable multi-fragmented pertrochanteric fracture, put a long cephalomedullary nail. This looks pretty good. It's a little short, but a lot of times they do that. You can see this, the screw probably slid a little bit, but in general, that looks pretty good. Again, another case, we've got a more stable fracture. This is a very good fracture for one of these sliding hip screws, although I would argue that this is fixed in a touch of varus, and I wouldn't have been happy with this, but luckily this went on to heal as far as I can tell. And then you've got your dreaded high energy subtrochanteric hip fracture, the most important part of which are the deforming forces of the muscles that put in. Remember, the muscles in and around the femoral neck are nothing, right? The only deforming force around the femoral neck is the capsule. But once you get to the subtrochanteric region, you've got the very strong deforming forces of multiple muscles in and around the thigh. And remember, this is just an anatomy lesson. So if you've got the lesser trochanter still attached to the proximal portion, what you're going to get is a very bad flexion deformity of that subtrochanteric femur. That hip's going to flex up, and you're going to have a real hard time fixing it. So as you see from my mentor and colleague, Adam Levin, in the way he titled this slide, open the toolbox. Subtrochanteric femur fractures are very, very difficult to deal with. I'm sure Kelly's got her tricks that work for her. I give myself what I call the 15-minute rule. If I can't reduce this thing closed in 15 minutes, I open these fractures, put a very small reduction clamp like you see here, even sometimes a very small wire around them to hold them in place, because what you want to avoid is fixing these in the wrong position. You're much better off making an open incision, fixing these appropriately with either a plate and screw construct like you see here, or a blade plate construct like you see on the right side of the screen, because you never want to fix these poorly. This is a beautiful example of a blade plate construct done by one of my colleagues. This looks fantastic. This is exactly what you want to see. And you got to be careful of those deforming forces because they make it very hard. Because what you want to avoid is this, where these slides are from Joe, and thank you to Joe for these slides. It is a great example of what happens is if you don't correct that deformity early on, you will fix the fracture exactly as it lies. And as you can see here, your proximal femur will be sitting up high, your femoral shaft will be sitting down here, and you'll put your nail in like that. And this is a disaster. This isn't going to heal. This is going to have a really hard time. So you always want to make sure that you recognize the deforming force here is that iliopsoas pulling on the lesser trochanter. You reduce that fracture first, get your nail down all the way, and you can do a beautiful job like you saw on some of those other x-rays. So in summary, you want to classify your hip fractures in useful patterns that help guide treatment. So you want to understand intracapsular or extracapsular. How is the blood supply to my femoral head? And what does my patient look like? Are they a 56-year-old active orthopedic surgeon, or a 90-year-old household ambulator that already uses a walker, they had a 19-year-old on their motorcycle. These things matter in terms of how quickly we treat them, but also matter in what treatment we use. Disruption of the medial femoral circumflex artery can risk AVN, especially in young patients, and the longer they are displaced, the higher the risk of AVN. So you want to reduce these fractures quickly and anatomically and try to fix them as best as you can. And in older patients, while we want to get them to the operating room in expeditious fashion, medical optimization, it trumps that. So no, you don't need to wait 72 hours to get them off their blood thinner, but you do want to make sure their heart and lungs are safe enough to go through the surgery so that you have a healthy patient on the other end that can get up and mobilize quickly.